Yes, I want to make sure that we have our keynote panelists on. If we can identify them and highlight them, if we will. I am happy to introduce Tu Quach, who is the president of Asian Health Services in California and a member of the National Advisory Group for the Workforce Summit. Tu will be moderating this session of our what we call the Big Three of our HRSA Associate Administrator. So without further ado, I'll turn it over to Tu.
Thanks so much, Gerard. I just want to make sure that we have our keynote speakers on. I know that there are some difficulties. Do we know if they're on, Gerard? Just want to make sure.
Yes, they are.
Oh, great. Okay.
I see all four of you.
Wonderful, wonderful. Well,
Yep.
Hello and welcome, everyone. I'm so glad that you're able to join across the country and that you were able to hop back on. It is really nice. And I always think we're from health centers, so we always know how to pivot. Again, my name is Tu Quach, and I proudly work at Asian Health Services. We're a federally qualified health center in Northern California. And I actually started volunteering here when I was just a college student because the patients here remind me of my own family. When my family and I arrived in the US as refugees from Vietnam, we had nothing. We didn't speak any English, relied on Medicaid, food stamps, and other forms of public assistance. So even at the age of 7, I was serving as a child interpreter for my parents as they navigated through the difficult and complex healthcare system. And looking back, I wish they had a health center that could have provided them with culturally and linguistically competent care. That has always been my inspiration for working here for the many years. I am so grateful to the many, many health centers across the country that does the hard work of providing care and addressing social determinants of health for the millions of underserved patients. Yet, while extremely rewarding and fulfilling, the work can really take its toll on our staff. We often talk about centering patients in this work. It's just as important to center our very hardworking and dedicated staff, now more than ever. After 3 years of the relentless pandemic and everything else, it's time we put the focus on the wellness of our frontline heroes, because they truly are heroes. I'm so grateful for this virtual summit, where we can hear from experts from all over, share strategies and lessons learned. And I'm really, really honored to be able to moderate this amazing keynote panel with 3 exceptional panelists who will share their strategies for enhancing wellness in the health center workforce. So I'm going to go and introduce each one of them. And I just want to say their shortened bios do not fully do justice for the many accomplishments and years of service. So first up, we have Jim McCrae, who became an associate administrator for primary health care in the U.S. Department of Health and Human Services, Health Resources and Services Administration, HRSA, in May of 2006. He has led HRSA's Bureau of Primary Health Care for more than 15 years, managing a budget of $5.7 billion that supports nearly 1,400 health centers, which operate approximately 15,000 service delivery sites in every state, the District of Columbia, Puerto Rico, the U.S. Virgin Islands, and the Pacific Basin. Next up, we have Dr. Luis Padilla, who is the Associate Administrator for Health Workforce at HRSA. He also serves as the Director of the National Health Services Corps. Dr. Padilla was appointed Associate Administrator for the Bureau of Health Workforce in May of 2016. Prior to joining the Bureau, Dr. Padilla was Senior Health Policy Advisor to the CEO of Unity Healthcare in Washington, D.C., a federally qualified health center network with over 100,000 patients. He is also a family physician. Last but not least, we have Tom Morris, who serves as the Associate Administrator for the Rural Health Policy in HRSA. In that role, Tom oversees the work of the Federal Office of Rural Health Policy, which is charged with advising the U.S. Department of Health and Human Services Secretary on rural health issues. The office, which has an annual budget of $317 million, administers a range of research and capacity building grant programs that serve rural communities. Welcome to our panelists, and thank you so much for making time for this important topic. So I'm going to jump into the questions, and the first one is going to be towards Jim. So Jim, we know that the Bureau of Primary Healthcare conducted the Workforce Wellness Survey the past year. While we know you are still analyzing and finalizing the results, are there any preliminary findings or early returns that you're able to share with us?
Great. Thank you so much, too, for being here and being a part of this panel. Really happy to be with my colleagues also. But a big thank you to all of you out in the health center community. Thank you for making the time today and over the next several hours and days to really focus on a critical issue for us, the health center workforce. I think as many of you, and you probably heard me say, 70 to 75% of the budgets of health centers actually goes into personnel. And it's a reflection of, where your dollars are is where your support needs to be. And we feel like we need to do an even better job of supporting our workforce in the health center program with some of the activities that we're doing. Margaret actually touched upon a real effort that we're trying to do around training and really building our own pipeline. But we also are worried about our current workforce and how are things playing out there. And we knew before COVID that primary care was stressed and our workforce was under an enormous amount of pressure to do more and more for the patients who need their services. And that actually was when we began to think about doing our workforce wellness survey. Then, of course, COVID happened and just put a greater spotlight and greater pressure on our workforce. But we decided to go ahead and do the survey anyway, because we felt like it was important to get a real temperature check of what our workforce was feeling. And there was a little bit of trepidation, I'll be honest, when we engaged with health centers across the country. There was definitely some real concerns about, number one, why are you doing this? Number two, why are you doing it in the middle of COVID? And what are you ultimately going to use this for? And I will just say that the reason why we decided to do this is because we just, again, feel like our workforce is so critically important. And it's so critical to all of us to make sure that we are supporting our staffs in the best way. So we felt like that was critically important. So we did the survey from November of 2022 until January of 2023. We were very excited because we had almost half of the health centers across the country agree to participate. So that was a great number. We were really happy for the first time we've ever done this. The second thing is we received responses from over 50,000 staff across the health center movement. So that was fantastic. We also had 22 health centers that had more than 80% participation of their staff. So that was great. In terms of some of the preliminary results, they actually turned out to be better than we anticipated. We will be sharing the full results later this summer, the national picture, and then breaking it down at the state level. The individual health centers who participated in the survey have already received their survey results back. And I'm very pleased to say that many of the health centers have already started asking the question, when are you going to do this again? This is so helpful. So I think that initial trepidation and concern is starting to go away with the results that we're starting to see. But in terms of those results, I don't think it'll be surprising. Strong mission orientation, that was the highest rated area, not a big surprise at all. The meaningfulness of the work that people do at the health center and in their health center programs was the second highest. Engagement was actually the third highest in terms of what we saw. And then my work team and supervision and leadership and positive workplace culture scored next highest. So we saw some really positive results and really good scores in terms of that piece. Not surprisingly, the areas that scored lower were around the whole issue of burnout. I think a lot of people are really feeling exhausted and really figuring out how to recharge their batteries and support one another better. Workload was another big issue. And again, that's not a surprise. I think if anything, COVID just put a greater emphasis on the need for primary care and what we expect from it, but workload was a big issue. And then I think just the environment that people work in, the sort of disconnect between what people were trying to do in response to the pandemic and some of the political challenges in that space, and just really, I think, feeling more question than they ever had before in terms of just what they were trying to do for their patients and their communities. So we got some, I think, really great results. As I said, we plan to do a full rollout later this summer. We will provide information to all of the health centers. They'll be able to see, of course, their individual results, but then comparison reports to see how they compare to other health centers across the country within their state and nationally. We will be providing this information to our primary care associations as well as our national partners. And this data will be up on our website so everybody can see it at a national level. What we hope to be able to do with these resources is, number one, I think be able to provide a better national picture of what is happening with the health center workforce. We are continually asked, especially with reauthorization happening, how is the workforce doing in the health center program? What are the additional needs? Now we're going to have some concrete quantifiable data to be able to talk about that more clearly to policymakers and folks who are making decisions about reauthorization and funding. We also, though, we're going to, of course, use it with our technical assistance partners to identify both areas of strength as well as areas for improvement in terms of how can we better support health centers out there. The last thing that we're hoping to be able to do, of course, is to provide information to individual health centers. And we have a whole variety of things that we're looking at. Everything from developing learning collaboratives so health centers can learn from one another. Of course, doing some technical assistance webinars targeted specifically to the areas that particular health centers are maybe struggling with. We're also looking at doing case studies as well as office hours, but basically an opportunity for folks to learn from one another about what is working and what is a challenge. So really excited about this. You know, doing this survey was one of those decisions where it's like, do you do it? Do you not do it? And we made the decision that let's do it. And we'll see where we end up. And, you know, not surprisingly, health centers have done an amazing job in spite of all of the challenges that primary care is facing, in spite of all of the challenges with COVID. And I think really is a testament to the work that we all do in the health center program. Doesn't mean that there aren't things that we need to work and support on to make sure that we continue to be the employer of choice beyond just being a mission-oriented organization. But this, I think, will really put us on a path to go forward and do even greater things together. So I'll turn it back to you, too.
Thanks so much, Jim. I know many of us are really interested in the results and we'll be checking it out on the websites and such. I wanted to go next to Dr. Padilla to get some of your thoughts on workforce wellness. Trying to see if Dr. Padilla is on. There he is. Oops, Dr. Padilla, I think, oh, great.
You see me and hear me?
Yes, we can hear you.
Oh, thank you, Thu. And thank you for having me participate in this workforce summit, such an important topic to discuss, and been very fortunate to be included in your discussions in prior ones. So glad that you're full capacity today. So talking about resiliency really is a part of what we're doing right now, and recognizing that the pandemic has really hit our workforce hard across all areas of work, not just in community-based training. But what I want to share is our overall effort to improve and assist the capacity of organizations like FQHCs and others to increase their capacity to do education and training. Obviously, the most recent effort and the ongoing effort with the Health Professions Education and Training Initiative, the partnership with BIPIC, has been quite successful in many regards. And just to recap, we kicked this initiative off in 2020, and I just want to thank Jim again and his team for their leadership in partnering with us on this. But that collaboration, which has led to funding in all 52 states and regional primary care associations of full-time FTE dedicated to workforce, is really one of the more significant accomplishments of this overall effort. Obviously, the RTAT that was developed by CHCI Inc., and I want to again thank Margaret and her team for developing that tool, deploying that tool, and sending out all the reports, more than 1,060 reports nationally to all the health centers that participated. We think that overall this has been very successful. It was the first of its kind to look at where health centers were in terms of their evolution and their path of education and training. And we hadn't seen this data before, and we recognize that it wasn't perfect. It didn't capture everything, and we want to find ways to to use additional data sources, including the survey that BIPIC just deployed in conjunction with the SARTAT. But the response was overwhelming. Our target originally was 70% or 50%. We achieved more than 70% response rate. Over 1,000 health centers that participated in that and responded really gave us good insight into where health centers were. And just to highlight some of the responses nationally, 40% of those respondents indicated that they were currently sustaining health professionals training programs. That was the first time that we had at least a snapshot of how many of them were conducting health professionals training programs. And I think one of the more telling statistics here was that only 1.5% indicated of those who responded that their health center was not engaged in any professional training program. And that to us was really promising. That meant that many health centers, at least the ones that responded here, were already doing some education and training. And that was something to build off of. But obviously have a lot of room to grow. And one of the things that we're focused on now that the readiness tool has been deployed, the data has been provided nationally to health centers and PCAs, is working on that third component of workforce development plans. And that's where our efforts are focused right now. How can we assist health centers in developing those plans? We know that it's an arduous effort to get support to develop those, start to think of the partnerships that you need and how you might be able to use both federal, state, and local funding to support your overall efforts to increase your workforce. But we think that that's the work ahead for us. How can we assist you in establishing those partnerships with academic organizations? How can we further what you are already doing right now in terms of education and training? Many health centers are already taking advantage of our numerous workforce programs to bolster their workforce, both now and in the future. But how do we increase that capacity? And one of the things that we launched last year as a part of this, recognizing that we needed to better inform health centers and PCAs about our programs, is an initiative that we call the Regional Workforce Workshops. We were fortunate that we were able to hit 6 regions last year, starting in the fall of 22 and then going on in spring of 23. We have completed these workshops in regions 1, 2, 4, 5, 6, and 7. We have 4 regional workshops planned in this year, including region 9, regions 3, 8, and 10. So we want to complete that process to at least complete what we saw was an important part of this overall effort, and that is making you more familiar and aware of our programs, how they relate to health centers and other community-based organizations, how we can facilitate partnerships, how we can share the data that we're producing at all levels of our programs. We've gone a long way in externalizing a great deal of our data that we haven't had before. And how do we put that in your hands, make it useful to you, that you can utilize it not only for workforce development efforts, those plans, but also those that are starting and wanting to partner and wanting to, if you will, advocate at the state level for funding or take advantage of funding available at the state and local level. We think that this data is really important to get out. But we recognize that there have been some challenges. We've already gotten feedback from PCAs and those who have participated in our workshops, wanting us to continue to work on bidirectional communication, wanting us to recognize that precepting, and while that is an effort underway, and we've put out some funding to support some of that, we're still limited in hearing from all of you that more precepting support, more infrastructure support, the challenges that you're having in not just recruiting, but also retaining staff. You're losing staff to other health systems and organizations that are also challenged with workforce needs. So we're hearing that in addition to, again, your workforce that you currently have and has been with you is feeling not just the pandemic, but even before then, the impact of burnout, wellness. And while we've put out funding in that area, there's still more work to be done. So for us, what's to look ahead is how do we improve that bidirectional communication that you're asking for? How do we promote the evidence-based strategies, those models, those practices that we have begun sharing during these workshops, these PCA workshops? How do we do more of that? And how do we complete not only the regional workshops that we have, but how do we enhance them, modify them, make adjustments to them just as useful as they can be to all of you that participate? So I think the work ahead for us is is promising in that the health centers that have been working with us, not only on the RTAT, the HBET, the workshops, have demonstrated a willingness to engage in health workforce education and training, but we see a potential for broader engagement, not only with community-based organizations, but with academic institutions that also are showing a willingness to partner with community-based organizations, disseminating our best practices, models of education and training that we believe are effective and ready to be expanded. And then also doing more to make sure that community-based organizations in rural and underserved areas are aware and able to come in for funding as best that they can, both either directly or in partnership with academic institutions that we typically fund. Thank you.
Thanks so much, Dr. Padilla. That was really helpful to hear about the different programs and some of the learnings from it. I wanted to go to Tom and see if you had any thoughts on some of the workforce wellness that we're discussing. Hi,
Well,
Tom.
first, thanks for having me, and it's great to be a part of this panel. So many of the health centers are in rural areas and serve, really challenging situations. So I can only imagine everything Jim and Louise have already talked about is just even more pronounced for many of the smaller health centers serving to very disparate populations. I think obviously I think they've covered the ground really well. I agree with everything they've said. I think one of the things is what's new and what's emerging. And as I look back and I thought about that, the strategies really haven't changed over the years because I think they still work. The whole notion of growing your own, of getting people, if we take people in health profession programs and expose them to training, the academic literature is pretty solid here. If you expose them to training in rural and underserved, they're much more likely to consider it. That's easy to say, hard to do. If you take on students, that adds to your burden. We get all that. You assume costs when doing that, and you can't recover them. So, it's one of those real challenges in that I think everybody knows what works and how to do it. Challenge, of course, I saw it pop up in the chat, is how do you fund it, and then more importantly, how do you sustain it? And I wish I had a nice, easy solution for you. I don't, other than you have no real choice other than to keep plugging away and do the best you can on it. I think one of the real dilemmas, and I think it's true for health centers, it's true for a lot of the other provider types we work for, is the ultimate beneficiaries of all of the health profession training programs at HRSA are the health centers, are other clinics and hospitals in rural communities. They're not the ones who tend to apply for the funding because it goes to educational institutions. So, how to Luis's point, I think, how do you create more academic community partnerships? And I sort of believe that they need you more than perhaps you even need them, in the sense that they need to get their students out and rotated to meet their clinical training requirements. But those relationships, sort of have to be nurtured over time. And that is, I think, the real challenge. And how do we sort of nurture those along the way? We do have some small amount of funding in our office through our community-based program to fund activities that could be focused on workforce. Our grant authority is pretty broad. It just says improve access to or coordination of care in rural communities, and health centers have really tapped into this funding. A lot of times, though, for like chronic disease management and really important things, but they could use the same funding for workforce partnerships. And it's not permanent funding, but it could be startup funding. And I think the one I would probably think about that would be worth really thinking about is our network planning grants. We do about anywhere from 15 to 25 of these a year, and it's $100,000, and it's just to bring stakeholders together. So I could easily see a partnership where health centers might come together with their AHEC, their PCA, their State Office of Rural Health, some of their educational institutions, and really think about, okay, how do we use this money to get a partnership started? And then what sort of a network could we create that we could then sustain beyond that? Especially when you consider the money you're spending on recruitment and retention. I mean, what does it cost to hire a firm to do that right now, to get a doctor? $60,000, $70,000. And there may be other ways to think about that. And maybe our grants could be a jump start towards that. One of the activities we've funded in the past year has been to sort of expand the work of the National Rural Recruitment and Retention Network, or what we call 3RNet. Just about all of the states are members of this. And some of the states are very actively engaged. And I imagine some of you work very closely with your state coordinator, but some of them are more limited in their resources and may just be able to only post jobs. So we really charged the 3RNet folks with sort of thinking more broadly about what they can do. So they now have an annual 3RNet academy where you can sign up and kind of like this workshop today, but even more hands-on, focused on strategies. You could sign up and be part of that, to sort of learn from them what the experience that they've had in sort of recruitment and retention over the course of the last 25 years. Because I think at its core, when the states that do this really well, it's community development. It's actively working with those clinicians, not just to get them to come consider working in your health center, but to continually recruit them every day, every week, every month, because it's never ending. And then realizing though that the costs of recruitment are growing each year. The thing that 3RNet is rolling out, I think, probably the next couple of weeks, is a new activity called 3RNet Tools. And so these are very affordable sort of resources that people could get and sort of tap into to sort of implement their own recruiting strategies. So I would say stay tuned for that. We'd love your feedback on whether you find it valuable or not, because if you do, great. If you have suggestions on ways to improve, we want to continue to expand what they can offer, both at the state level, but also at the individual community level. And the only way we're going to know that is if we hear more from you all. Two other points I guess I just hit is I think, the health centers were sort of the birthing place, I think, in many ways of the community health worker, movement. Certainly with the investments from the American Rescue Plan that Luis had, and we had a smaller amount, I think we've really seen an expansion of those. The sustainability is always a question. I think what Luis did in terms of aligning with the Department of Labor around traineeships really made a lot of sense and may help towards that sustainability. With our funding, what we've thought about trying out was sort of cross-training community health workers, not just to do their normal sort of, coaching people through the healthcare, kind of like what you talked about with your parents. But then also, could you cross-train them in coding and billing and sort of other navigation activities so that they could show more direct value? Could they do benefits counseling? Because if they don't show direct financial benefit to that CEO, it's very hard to keep paying that salary. I am encouraged that we're seeing more health centers and community health worker activities being able to negotiate directly with Medicaid managed care organizations to fund community health worker activities. I think probably what we lack now is sort of a database or a compendium of showing who did it well, how did you do it, and do you have any ideas on how I could leverage what you've done? I know we've worked closely with a foundation in West Virginia that's been very successful at sort of getting managed care organizations to sort of contribute towards this. And if anybody's interested in learning more about that, please drop me an email. I guess the last point I'd touch on is I do think there's a tremendous opportunity in the behavioral health space this year because of the changes Medicare made in terms of for this year with general supervision for family counselors and professional counselors and family therapists. And then next year, they'll be able to bill directly. Unfortunately, for whatever reason, CMS in its rulemaking didn't allow to extend that general supervision to health centers or rural health clinics. So this year, we're not able to fully leverage that. But starting next year, you will be able to bill directly for that. And then the hope is that for other professions that can do the general supervision, like peer recovery, addiction specialists, those sorts of providers, those are a little easier to recruit to underserved and rural communities. And maybe they can help plug some of these gaps we see in the behavioral health space, given the paucity of psychiatrists and psychologists and even licensed clinical social workers. So the rulemaking is going to be coming out on that pretty soon from CMS. So I think the other thing is just really paying attention to it and making sure it works in the context of community health centers. Those are a few thoughts for what it's worth.
Oh, it's worth quite a lot. Thanks so much, Tom. You cover so much. I just want to go back to Jim and, this concept of growing our own. That's so critical as we think about the communities in which we serve. What would you say to our health center board members and even leadership about the return on investment when we think about growing our own?
Well, it's interesting. I think most of you know we are facing a mandatory funding cliff in the health center program. Folks are aware of that, I'm assuming. So we've had the opportunity to engage with the folks on the Hill, both on the House and the Senate side, and they've talked a lot to us about workforce and, how do we develop the workforce. Luis has been an instrumental partner. Tom's been a great supporter in terms of what we're doing with FQHCs. But they have asked, like, what can health centers do in this space? And I said, initially, my experience, when this is, more than 10 years ago, I think most people, when they thought about workforce in the health center program, they immediately gravitated to the National Service Corps, because that was a way to get clinicians in, especially through the loan repayment program, to address immediate needs. What I have shared with people on the Hill, and I'll share it with you all, is that what I've really seen in the last 5 years, especially with the introduction of the Teaching Health Center program, but also our nurse practitioner programs, other programs that health centers are working on, there is so much more of an emphasis in the health center community around training, and that we need to be a part of it. Otherwise, it's not going to happen. And while the National Service Corps is still essential, that's just putting a Band-Aid on the situation. We ultimately have to be part of training the future workforce. Otherwise, we're not going to have it. And what I have seen, and I've seen it from board members, I've seen it from CEOs, CMOs, the staff, if we don't do the training ourselves, it's not going to happen, and people aren't going to come to the health center program. So yes, it is not inexpensive. It does take time and resources away. On the other hand, it is one of the key solutions if we're actually going to have the workforce that we want for the 21st century, if we want people to go into primary care, if we want them to go into underserved communities, if we want to make sure that we have staff that coming out of training actually can do what we need in the health center program. So I have seen a remarkable pivot, and I'm really excited about it. We are trying to support that with, of course, the new elements we've added to our UDS around training. It really shows the breadth and depth of what health centers are doing. But we're also looking at ways from the service delivery side. How can we support it? So we have created opportunities in our grant announcements to say, if you need, when we have construction dollars, space to support expanded training rooms and places for students to be able to get, classroom kind of didactic training, let's do that. If we can, create opportunities working with Luis around supporting not just the academic side, but the service delivery side, we're trying to look at that. So I would just say, if you haven't made the leap yet, and I would say at this point, most health centers have, this is absolutely essential. And you are building it, not just for yourselves, but for the greater movement. So.
Thanks so much, Jim. And Dr. Padilla, I wanted to ask you the same question. What would you say to our boards and leadership about growing our own and the return on investments?
Well, I think it's absolutely critical, and I think many of you have heard me speak on this before. My charge to all of you is it needs to be part of your ongoing mission. The health center movement, for certainly the years that I've been involved in before, have been, and rightly so, focused on healthcare delivery to the underserved. And I think that that's a mission that needs to continue. But the flip side of that mission is the workforce, and I think we're seeing that now play itself out. I don't think that continue to operate with having workforce be a second thought, whether it's on value-based purchasing, because that discussion is going to come back, or anything else. We have to continue to say you can't do health service delivery without looking at workforce. It's on the same. So I think, if anything else, every day I hear how someone is interested in workforce, and I think that's great. But you have to really intentionally look at what's happening right now and say, okay, more than just saying it's important, what are we going to do to make sure that some of the paradigms of health workforce education and training change? Because what we're dealing with here are paradigms that are decades long, whether it's on admissions, matriculation, where people go to graduate, and it's changing bit by bit. So it's not just on the health center side, but also on this traditionally based academic environment. And we're trying our best to say, has to be a new world. And I think if anything positive has come out of the pandemic is, sadly, they're feeling the workforce crunch now more than ever. I think health centers have always felt that, because it's been a mission-driven movement relying on those who want to do that kind of work. And other organizations have been a bit immune. Now they're not immune to that, whether it's hospitals, academic institutions, everyone has really felt the pinch. And now let's not lose the opportunity that this dialogue has come up about workforce. What does that mean in terms of these paradigms? So I think that health centers are on the right path right now. What we've seen, according to, when we're looking at our data, more FQHCs and community-based organizations are coming in for our funding. Even the most recent one on our substance use treatment and prevention, where we got some expanded authority to support provisional licensing. I know of health centers who came in for that funding. So that wouldn't have happened before if we weren't being more intentional about the funding that's available, being more intentional with taking the opportunities to engage with those staff about the importance of community-based training. This is a paradigm shift. While we say, oh, the recipe is the same, it hasn't happened in mass. And I think more and more now, both sides are recognizing the importance. As Tom said, they may need us more than you need them, and us by meaning those community-based organizations, but it hasn't hit home to them the importance. We need to continue to say there's a value proposition on both sides. Because I don't think we're going to set up a situation where one wins and the other one loses. We have to sort of set that scenario to say it's in your best interest to shift in this direction.
Thank you, Dr. Padilla. I wanted to go back to Tom to see if you had any thoughts, especially when it comes to the rural health centers.
Beyond what I said, I'm not sure I have anything, other than that, other than an acknowledgement of the fact that even more so than all the health centers, they're wearing multiple hats, but I think it's even more pronounced in rural. And the burnout factor, I think, can get a little bit higher there because you may have, especially at some of the smaller access points, a single clinician, whether it's a physician, nurse practitioner, PA, and that's a really tough dynamic over time. So, encouraged to see the resiliency funding that the Congress provided to BHW to do that. But I think the rural urban dynamic is probably less impactful here than the overall issues I think that Jim and Luis laid out. I suspect that health centers feel the same way about all these issues that they've raised. It may just be a little bit harder in rural.
Great, thank you. So now we're going to take some questions from the audience, and I know that there are a few. I think the first one is directed at Jim about whether the PCAs can get the information. This is referring to the workforce wellness survey before it goes out live on the website or it gets released to the media, just so they have a little bit of lead time to prepare.
We will figure that out. So we will make sure that it is available. So yes, we will do that.
Great. And I'm just looking at the questions that we have. There were a number of them. I know that, sorry, I'm just scanning through. There's a lot of comments about this. And there was also a question about whether folks who are interested in being part of the region that Dr. Padilla talked about could also be joining on that. And I know that folks are also putting their names on that piece. And then there was a question, Dr. Padilla, for where they can find dates for the regional workshop and be involved in planning for the region as well.
Yeah, so we will, and we've already started collecting some emails here to make sure that those that are in those regions have that invite when it comes out. We typically will announce that about 3 weeks before, 3 to 4 weeks before we launch them. And what we have done since we started the workshops is incorporating a period of input from the regions that are going to participate. So it's not just us setting the agenda. We really want to make sure that the partners that need to be on those workshops are on. We've added our rural partners. We've added workforce boards, state boards to those invites as well. So we really want the participants to drive the agenda, what they want to hear about, the programs that we want highlighted, because from the outset, we realized that these need to be tailored to the region and even perhaps the states within those regions. Some regions said, hey, for us, nursing is really what we want to hear about. Others said oral health is what we want to hear. So we're not really taking the approach of one size fits all, right? What is it that specifically in your region you want to hear about? And we'll include that. And we're really highlighting what's happening within those regions and states that we're supporting to highlight those best practices and models that other participants and states might be able to take advantage of. If you don't mind, I saw one of the questions here that I thought was really a good question. And that is, what does it mean to build your own paradigms? They said examples would be encouraged. Okay, this is important because building your own can have different connotations. And health centers have started on the path of 2 different versions of build your own. One is we're going to go after a program and get accreditation. So CHC Ewing, and not Inc., but I think a Community Health Center University got accreditation for PAs and social workers. I think it was for PAs most recently. That is one form of building your own, where you're going through the accreditation process and starting your own school. And that's what they did. But what that does is it puts you in the traditional model of accreditation, right? You're getting accredited in the usual way that programs get accredited. It doesn't take into account necessarily what you want as a future workforce. So that's one model of, quote, build your own. The other is to starting completely new and say, we want to develop a workforce that is reflective of our needs, students and trainees that have the characteristics that we want, that will ultimately go into these organizations. That's a very different model than going after a traditional accreditation. So thank you for that, because building your own can take on different connotations, and it's a different lift depending on the way that you go. And in terms of paradigms, I would say the most glaring one is actually two within our portfolio, THC-GME. That is a paradigm shift from the way graduate medical education is funded in this country. The CMS model funds hospitals to train residents. The THC-GME model funds community-based programs to train residents. That's very, very different. So that's just one start. The other one is the nurse practitioner residency program that we support. One is very traditional and academic, and the ones that we really want to support, we support both, are the ones that are community-based. That too is a paradigm shift. That did not occur before our funding. I mean, it was occurring, but the federal government space now in that is another paradigm shift, if you will. Sorry for that long-winded response there.
No, that was perfect to bring it all together. I wanted to go to Tom. You talked about behavioral health and the changes and having the LMFT. There was a question about how can we get LPCCs to have supervised hours so that they can get their license, and our FQHCs able to bill for that.
That's the licensed professional counselors.
Mm-hmm.
Yeah, I mean, like, so the big change for 2023 was moving them from where, you had to have direct supervision, which is, cumbersome, to general. So that authority exists for this year, and then starting next year, it becomes moot because they can bill directly. So, I think we're sort of in a holding pattern for this year, especially since they didn't really extend it to the FQHC setting. I think, though, so that will solve itself just because in the omnibus they gave direct billing. I think the larger challenge, I think both for community health centers, but also other community-based mental health providers, is this other range of professionals that's going to fall into that general supervision category, because it will enable you to put people off site. Like, you won't have to be on site where their supervising clinician is. General, it's a much more flexible model. So especially as I think about health centers with multiple access points, you can have one at a hub, and they can be supervising 5, 6, 7, peer recovery support or addiction specialists out in there. And so I think the challenge is getting CMS to, and they have the authority, I think, to extend it to RHCs and FQHCs so they can do the same thing that any sort of physician fee schedule provider could do as well, but under the unified payment of the FQHC.
Yeah, no, that's great, because there's such a need for mental health and behavioral health services. So this is really critical. Dr. Padilla, there's another question for you. The funding you addressed, what would be your recommendations, i.e. program development? I think you mentioned some of the funding.
Yeah, I saw that question. I wasn't sure. I need a little bit more context, but what I mean by program development. I would say if you're not already started on education and training, to get started. I think many health centers and community-based organizations are already on that path, but they may be doing it ad hoc. I think if you're a part of the regions, those regions that I mentioned in those workshops, participate. Come in here about what funding we currently have available, what's coming up next, how they operate, because you hear from our subject matter experts on how they work, because not all of them are directly available to health centers. That's the first thing. Not all of our programming health centers are directly eligible as primary recipients. They, unfortunately, many of them, they need to partner. But more and more, I think there's being appropriated programs that allow health centers to come in. For example, our nursing programs. All of those really require partnerships. Even our nurse practitioner residency programs require partnerships with academic health centers or academic centers and hospitals to survive. Even the teaching health center GME program requires willing hospitals to be venues for residents to train in addition to their outpatient community-based training. So I think we have such an array of programs that it's important to just become familiar. And I think that's the first best starting point. But if you're not already doing it, look into it. We have TA webinars when things are released. We're doing more and more pre-release as best we can to signal to the field that funding opportunities are becoming available soon.
Great, thank you. And Jim, you have your hand raised.
I have my hand raised because I actually wanted to ask Luis a question. I never get this opportunity in front of the entire crowd, so I figured I might as well do it. So, Luis, we've talked a lot over the years about just the developing the interest in the teaching health center program. Can you, I don't know whether you can, but can you share just a sense about how many applications you have gotten in, both on the sort of planning side and then the application side? Because I think we've seen pretty significant growth.
Yeah. So before ARP, we had limited amount of funding to put out new competitions, and there was a period of time before the ARP where we didn't have a competition at all. I think 2014 was the first time we had a competition before the ARP funding. So the 330 that we got in ARP allowed us the opportunity to expand the program. So we put out in total, I think it was 4 different competitions to expand, create new ones, and then to support the planning and development of new accredited residency programs. What we saw in the expansion GME, the regular GME program, was at times not enough applicants to meet some of our estimates of applicants that we would get. We were able to expend the money, but we thought we'd get more applicants. And I think part of that has historically been the sustainability of the funding. If you're going over a funding cliff every 2 years and the residency program takes 3 years, it makes you a little nervous about investing and starting a program. So we're encouraged that some of the activity on Hill has a much longer period of extension for this program beyond 2 years. The planning and development, what we saw was we had more than enough applicants to expend the money that we had. So we brought online, and we'll be bringing online 93 planning and development awardees, all of which are FQHCs, every single one, including, and actually some of them are rural health clinics as well, which we're very happy about. So all of those are on the path to develop residency programs. And then this next rounding of award, I think there's going to be some of those that we gave planning and development last year that are going to come in for our GME funding. That shows us that they were already moving towards not only establishing those programs, but getting ready for that funding. So we're encouraged. I think the issue really is, are we going to have enough funds from Congress to support all of that growth? Because I think that planning and development, and we have a technical assistance center from UNC that's supporting all of those planning and development awardees, is encouraged by what came in, but also it's a daunting task to establish these residency programs. And so we hope that Congress at the end of the day really is going to act to help support all of the growth that we've established so far. Does that help, Jim? I miss anything? Right.
Thanks so much. I know Tom has his hand raised, and I also want to point it out that Tom put in a link. I don't know if you also want to mention about the link as well, Tom.
Sure. I put in a link for the network planning program, just so folks could get a sense of what the application looks like. We release the notice of funding opportunity each fall, review in the winter, award in the summer. So it's something you could, it's probably our most accessible funding opportunity, and it requires multiple entities to come in together. But I wanted to follow up on Luis's thing. I should have mentioned this in my opening comments, because we share a TA center, because we also operate a GME program, the Rural Residency Planning and Development Grants. And what we've been able to do is get people through the accreditation process and then flip them either to Medicare or Medicaid in perpetuity. So often rural hospitals are the applicants, but they don't have to be. It could be a not-for-profit. There's a lot of ways to do this. I still think teaching health center is probably the better model for health centers, because it's tricky with the Medicare GME funding flows. You have to who bears all the costs, those sort of things. But having said that, particularly if your state is an aggressive state in terms of supporting Medicaid GME, it might be worth you know, if you have good relations with your rural hospital nearby, thinking about them because, you know, you're a natural place for them to get some of those primary care rotations, and some of the more hospital-based rotations could take place at a rural hospital. Some of them will have to go upstream to a larger tertiary. But, you know, we've had this grant for a number of years, and what we found is that, you know, we've been able to create several hundred accredited rural residency slots that are now funded in perpetuity by Medicare or Medicaid. So, you know, depending on the situation, teaching health center, traditional Medicare, Medicaid, GME, the rural GME folks, that's the name of the website that we share the TA center on. What I think they're really good at is sitting down with you and sitting in there and saying, well, if you want to go THC, you know, here are the things you need to think about. If you wanted to look at perhaps the more traditional residency model, here's how the RRPD works. So, you know, just Google rural GME. Even for your urban health centers, the lessons don't change any in terms of what they're telling you.
Great, thank you. And then here's another question. I think it's for Dr. Padilla, but any of you can answer. Are there any good models for overall programs? That is, training all types of workers, or should it be done by discipline? What are the multi-state efforts? Dr. Padilla?
Thank you. Yep. There are a lot of models out there with varying success on how they approach this. So there are successful ones for nursing, in partnership with academic institutions, for residency programs. It really, and I think this is related to another question that was in the chat, you know, where do you start? Overall, I would say, where do you have the most capacity to begin, right? Because I think if you're looking at THC, GME, and graduate medical education writ large, that's a steep effort. There's a lot. On the nursing side, it might be lighter. On the behavioral health, it might be lighter. We've seen health centers start at various points, whether it's in nursing or behavioral health or community health worker, other allied health. It really is more of where do you have the most capacity, and then could develop and enhance beyond that. Because I think starting from ground zero is probably pretty challenging, but taking stock in terms of what you're currently doing. I mean, again, the fact that so few health centers that responded to that survey said we're not doing any at all, means that many of you are already doing some, whether it's ad hoc. And I remember my time at Unity, we would have students come in all sorts of doors. And sometimes I'd say, who are you from? Where are you? We didn't have a handle on who was coming into the health center to be educated and trained. There's a first point. Like, where are these various entry points? Because what I saw is there's a clinician who had an affiliation with some school, and they said, hey, I'll take one of your students or two of your students. There needs to be a more coordinated, centralized process. Like, what are we currently doing in this space that we can better organize and coordinate? And we began that process at Unity, and we're better for it. So I would say, where are you now? Where's our biggest capacity? And let's flex that muscle rather than perhaps maybe creating all brand new ones.
Thank you, Dr. Padilla, and thanks for linking up all the questions. I really appreciate you keeping on top of the chat. I know that we're getting to the end and want to be respectful of your time, but I thought maybe one more question for all three of you. So for the last question, and this could be serious or fun, what advice would you give those of us in health center leadership trying to navigate this workforce crisis or challenge situation? And I know it's a hard one. Jim, do you want to go?
So, I think we're all struggling with it. I think, everybody is tired. Everybody is, trying to figure out what's the next right step. And I think what's most important is just to gather your teams around you, talk about what are the issues that are facing your workforce, coming up with plans of how to do it, both in the short term, the medium term, and the long term. And how do we energize and honestly get people who are, at least in my case, a lot younger than I am, in the door and into the program and into leadership, to really support them for the future of the program. I will tell you, I was just walking around the hallways here and I saw a whole set of younger folks that were in the Bureau of Primary Healthcare, and I, got to talk to them and they were so excited. And it's like, how do we make sure we keep that momentum? and that enthusiasm that, the next generations are going to have, and how do we create an environment to support it? And then honestly, like amongst ourselves, how do we recharge and support one another? So I wish I had like a magic wand, but I think it's just us working together and figuring it out together.
Oh, that's great advice. Want to see Tom, did you want to share your advice?
Well, it's herding cats, right? I guess if you're good at that, maybe you could pull this off. I'm not really sure. No, I mean, I think, the one thing when I've done site visits that I'm continually try to remember is that people get excited when students are rotating through, to Luis's point. It's nice when you know why they're there, sure. But, I think that being an educator and being a way to groom the next generation can be a motivator, and it can create a sense of energy in a clinical setting when I've been to both hospitals and clinics. And so, how do you build on that? I don't think any of us, see this as anything easy to do. Yet at the same time, what option is there but to plunge ahead and try new ideas?
Great, thank you. Dr. Padilla?
Yeah, as Jim and both Tom said, this is a big task. It's not easy. But I would say that, from a leadership perspective, I think leaders need to be on board with the investment in education and training. This is an investment. Just like you're investing in quality healthcare delivery, there needs to be an investment in quality education and training. I think the worst thing an organization could do is expose students to an organization that isn't ready for them, that isn't coordinated, and it doesn't have happy, or I should reframe that, joyful staff. Because when you do that, what we see time and time again is, just like everything else, you look at who's there. Is that the job I want, where I want it when I'm done? And if we're not showing the best side, and certainly we look at this from our funding opportunities, be prepared to do what you want to do. And if you're not, I think these future students and clinicians are going to make decisions elsewhere. They're going to say, I don't want to go into primary care because that's the way I'm going to be treated and worked and overworked. I don't want to go into a health center because they're not ready for me and they don't care about me or whatever. And I think that the mission part of delivering healthcare translates and could translate to education and training. I think that part of it comes out in whether it's Jim, us, Tom, what we hear over and over again, I'm here because of the mission. So I think you can draw those people in and you can draw students in, but they want to see a long-term investment here. They want to make sure that, this is an organization that I'm going to spend 5, 10, 15, 20 years at. So I think from a leadership perspective is, if you're going to make this investment, think about it. What's your wheelhouse? What's your strength? And show the best side of the organization that you can to your future workforce.
Right. Those are really wise advice. Thank you so much for making time for this very important summit. I know that there were some questions that we couldn't get through to, and then also some great comments. So we'll try to get a copy of those to you. But again, I just really want to thank you all for taking time to speak to all of us. And we look forward to hearing from you again in the near future. Thank you. And I'm going to thank you. And with that, I think I'm going to pass it back to Gerard.
Thank you so much too, Jim, Dr. Padilla, Tom, really appreciate you. Always willing to come back for this summit. Now I think this is the 3rd or 4th time in a row. So we greatly appreciate you for your support for the health centers and certainly for this summit as well.